excited to welcome Dr. Dan Stone to the podcast today. Dr. Stone is a urogynecologist in Phoenix, Arizona. Welcome.
Hey, thank you for having me.
We're super excited to have you today. Tell us a little bit about yourself.
Yeah, so I'm what they call a urogynecologist. The official name, which is much longer, but can somewhat describe us a little bit better, is female pelvic medicine and reconstructive surgeon. And so basically what we do is we treat disorders of the female pelvic floor. And my background is I went to medical school in Wisconsin, did some training in Arizona, and then Oklahoma for my subspecialty training, and then I'm back in Phoenix.
So there is an additional training that a urogynecologist does on top of regular med school.
Right. Yeah. So there's two pathways. One is, and this is my pathway, is OBGYN residency. And then you do a subspecialty or the urogynecology specialty. So it's 4 years of residency, 3 years of the subspecialty training. And then there's another pathway, which is urology training. And then you can do a 2-year subspecialty training.
Okay. And then a urogynecologist only sees women, but a urologist could see
men and women.
Men and women.
Yeah.
Okay. And then as a urogynecologist, are you an OBGYN? Do you ever do deliveries or anything like that?
I mean, in normal times, no. I guess during the pandemic, there was some situations that the hospital needed some people, and so I helped out during that time. But that was very unique. So, no. Okay. In general, we don't really deal with deliveries. Although sometimes, due to a lot of the things that I treat, have to do with
delivery.
Delivery.
Yeah.
And I have been called in to help do like extensive repairs after a traumatic childbirth injury. So.
Oh, wow. Okay. Yeah, cool. I think it's one of those specialties that a lot of women don't know about and kind of don't know who to see in the pathway. And I think they often start with an OBGYN,
right,
and then end up seeing you, for bigger issues. So today I wanted to talk a little bit about overactive bladder. It seems to me like I have heard a lot more about OAB in the last couple years. I don't know if it's that more women have it than they did before, or if it's just there's more treatments or more people are talking about it.
Yeah.
So why don't we start by, what is overactive bladder?
Yeah, so overactive bladder, and I think what's happened is over time we're becoming more and more comfortable talking about it because it is a very, very common disorder, but it includes several symptoms, and that's going to be urgency, so you have to rush to the restroom, frequency, where you feel like you're going all the time, and then nocturia, meaning you're getting up at night to use the restroom. And then the more severe form of that is urge urinary incontinence, where you try to rush to the restroom and you don't make it in time. And these are just very embarrassing issues, so people in general don't like to talk about it. But by the time we reach a certain age, like over age 65, a significant portion of the population has some form of overactive bladder.
Yeah. Is there a certain number of times that you would classify in a day could be considered OAB? I can imagine women listening to this being like, oh my gosh, do I have it? I go 10 times a day, or, is there a magic number per se, or is it just?
We have what is considered normal and abnormal, but when it really comes down to it is it bothering you? Is it affecting your life? Is it stopping you from doing the things that you would normally do? I think those questions are much more important than the number of times. But in general, if you're getting up more than one time a night, that's abnormal. If you're having to rush to the restroom and not making it, that would be abnormal. During the day, it's a little less defined. It's more about how bothersome it is for you.
Yeah, and I wonder, I was having a conversation with somebody, and I feel like now, you're hearing drink more water, drink more water, drink more water. And you get, people are drinking like 200 ounces of water a day or 100 ounces of water a day. And how much is that really contributing to the thought like, oh, I'm going all night, but you just had like 36 ounces right before you went to bed, know?
I think that contributes quite a bit. I mean, if you don't, and I don't want to assume people don't have other disorders, but as long as your kidneys are working okay and you're not having any other disorder that requires a large amount of water, you can safely assume that whatever comes in is going to come out. And so everyone's going to be different. So if you're like a marathon runner in Phoenix, Arizona, which is where we're at today, you're probably going to need a lot of water.
Right.
But if you're in an air-conditioned place and
sitting at your desk,
not sweating, you don't need a ton of water. Now, I usually tell people as long as that you should shoot for light yellow urine or colorless urine every now and again. But if it's always colorless, you're probably drinking too much.
Right.
That being said, if you're taking B vitamins, it makes your urine bright yellow anyway, so you can't really.
Don't try to counter that.
Right.
Right. Yeah, I think it's interesting. And one other question I had, because I've heard friends kind of talk about overactive bladder. Is it physical or is it neurological, or could it be both?
It could be both. Yeah.
Okay.
So there's physical components that play a role, and that can be due to pelvic organ prolapse, which is another condition that I treat, and that's when the bladder starts coming down. It's just in an abnormal location, and the bladder is not happy, so it wants to contract all the time. You can have like radiation, which is thankfully a little bit more rare, but that can create a very small bladder. But for the most part, it's more neurological. It's the bladder. I kind of think of it as like a kid, because I have a 4-year-old. The kid wants to do what she wants to do and not listen to the parents, and that's kind of how the bladder can be. It just wants to rule the roost and start telling the brain when to go instead of the other way around.
Okay.
And so it can be neurological, that connection between the brain and the bladder.
Okay. And as far as like treatments, are there stages of OAB, like where it could just be minor and you can take, I had a note that there are herbal treatments recommended for OAB, which is a little, I don't know, capsaicin. I don't know what corn silk is, but...
Yeah. I mean, I think we're limited because there's not like a capsaicin industry that's funding well-designed studies in this.
Right.
So I've never seen a study regarding those herbal medicines, but I think the conservative things that you can do is more like avoiding triggers. So avoiding things that make the bladder worse. So coffee, tea, soda, artificial sweeteners, juices, that's usually what we focus on first. But again, that's doesn't have a lot of great evidence behind it, but it's easy to do and it doesn't do any harm.
Yeah. And what about like exercising? I know in this, with pelvic floor disorders, a lot of people talk about Kegels.
Yeah.
And
so we focus on bladder training, and one phrase that we like to use is mind over bladder. And so the idea behind that, and we incorporate Kegels into that, but the idea behind that is you're trying to train your bladder that you're in charge and not the other way around. And so you keep a diary, find out how often you're going. So let's say, for example, you find that you're going every hour, or let's say every hour and a half, and that's frustrating you. So then you start to do bladder training. You would set it every hour and 15 minutes. You go on the dot, no matter what. And the next time you have an urge episode, you try to hold it, do Kegels, distract the bladder. And that's where the Kegels come in, distract the bladder. And then you go on your terms when you decide to go. And so you're trying to like teach the bladder that you're in charge, not the bladder.
Oh, that's interesting.
Yeah.
Yeah. Are people usually successful? Or,
No.
no.
It's a lot harder. It's a lot easier said than done.
Yeah, I would imagine that's pretty hard.
Yeah.
Because then eventually you'd be like with anything that we try, like when you're at the gym or whatever, you're like, okay, I'm over this. I'm going to go to the bathroom right now. How much does obesity play a role?
It's definitely a contributing factor, but also one of those things that it's very hard to do. Like we know that losing weight can help all sorts of things, but yeah.
Right. And I assume the same is true with smoking. I feel like smoking is a contributing factor to a lot of different disease states. So, ladies, if you're listening, it's time to stop and we can help. So,
yeah. But I'm not aware of any like good data behind herbal remedies. That being said, I mean, it might be worth a try, but it's not something I typically recommend strongly.
Right. No, I totally understand. I feel like in today's culture, a lot of people kind of think about seeking, is there something else I can do with alternative medicine before doing something? And we'll get into that in a little bit when we talk about incontinence and the length of time that women wait to go to the doctor. Do you think that it's the same for overactive bladder? Do you feel like women wait a long time to come?
Yeah, one, there's that stigma, like it's somewhat embarrassing, and two, I think that there's somewhat of a normalization of it, which we're always trying to fight, because there are things that you can do, and I guess if it doesn't bother you, that's great. But if it is bothering you, I feel like women owe it to themselves to be able to enjoy life, not have to worry about, not have to walk into a new space and map out every bathroom, because that's what women tell me they do. They walk in, they go to the mall, the first thing they're doing is looking, where are the bathrooms? Not that they have to use it right then and there, but they know that if they get that warning, they have 30 seconds to get there. And so I feel like women owe it to themselves to do something and not have to live like that.
Do you see women with overactive bladder wearing the feminine diapers and that kind of thing to safeguard themselves if they can't find a bathroom?
Yep, and that's the severe form of it, the urge incontinence. Yeah.
Yeah, I mean, I think for PAP, the normalization of these things is really, really top of mind for us and what we're trying to combat. I think in the age of digital media and social media, there are a lot of influencers that are out there telling women, like, it's a badge of honor if you're a mom, if you ruin your leggings by peeing in them 4 times a day. And we're like, no, that's not normal. It's not okay. Right. That's not a badge of honor.
Right.
You want to feel good about yourself and don't want to have to be looking for bathrooms or ruining your leggings.
And I think it's great that we can talk about it, that women can actually, or if we can talk about it more. I feel like that aspect of normalization is good, but I don't like I just have to live with it.
No, right. I think, that's really our mission. That's what we're talking about all the time. Like, seek treatment. There is help.
Yeah.
And I think the problem also is that sometimes women go to their regular doctor and, now they get to hear what a urogynecologist is by you speaking about it. But sometimes their internist may not know, exactly where they need to go. And so they end up going to a few different appointments before finally getting to the right person, and they're a little defeated and, are like, oh gosh, and I have another doctor's appointment. So we really are trying to get women to the right place right away. And we think that's super helpful. What do you do for women that have overactive bladder? What are the different things that you can do?
Yeah. So I usually divide it into 3 different areas. And the first one we've already kind of talked about, the conservative things like bladder training, trying to limit or restrict fluids at night, possibly, or even during the day, and do the bladder training, Kegels. So those are the conservative things that can be done. And then we usually move to medications after that. And there's two main classes of medications, and we usually talk about the risks and benefits of those and have them decide on whether or not they're at that stage that they want to try something.
And is that in pill form or?
Yep, pill form.
Okay.
Yeah. And then after that, there's these advanced therapies, and they can either be nerve stimulation therapies or Botox injection into the bladder.
Oh, so the same Botox you use for either beauty or migraines, I think.
Migraines, yeah.
Botox is a wonder.
Yeah, it paralyzes muscle, and that is one of the big problems in overactive bladder is that muscle of the bladder wall is too active. And so by partially paralyzing it, it can give some women a lot of benefit.
That's good. And I would think that, do you have to have more than one injection? Does it wear off? Do you keep going back or?
Yeah, you do, unfortunately. Okay. I mean, so I guess both the good part and the bad part is it does need to be repeated, but it lasts usually 6 to 9 months. So.
Oh, that's actually pretty long. Yeah. I was thinking it would be like a monthly thing. So
no, 6 to 9 months. So
that's really good.
Yeah.
I would think that, I don't know. I guess my feeling is I would rather do that than take medicine every day. But, I think to each his own, which is really good.
Well, there's always a downside to everything.
Of course.
With Botox injections, sometimes it can be paralyzed too much. We never mean to paralyze it too much, but if you paralyze the bladder too much, then you have other problems, and that's happens in about 1 out of 20 patients where they have trouble emptying the bladder.
Okay.
So
it's the opposite.
Right, the opposite. Yeah, exactly.
Okay.
So and we always talk about that, kind of weigh those.
Risk, reward. Are there any surgical treatments?
Yeah, so there's 2 nerve stimulation treatments, and that are at least FDA approved right now. There's some more coming on, or at least in the FDA approval process. But one's an ankle stimulation, and that's an outpatient. Yeah, it's kind of strange.
That's interesting.
It's this ankle stimulation, and this nerve that comes from the ankle goes all the way up into the pelvis and meets up with the bladder nerves. And by stimulating that nerve, we can help the bladder and the brain communicate better. And that's a weekly therapy, so not really a surgery, although some of the FDA or some of the studies that they're doing or some of the procedures that are still in the FDA process involve an ankle implant, actually.
Oh, wow.
Yeah, but those aren't actually available right now. The other one is a sacral nerve implant. And so sacral nerve, that's the nerve in the pelvis.
Right.
And so that is a surgery, and we stimulate that nerve. And that, it's as close to a cure as we can get because that implant can last up to 15 years.
Oh, wow.
Yeah.
Oh, that's great. And the ankle one, is it like going to physical therapy? Like you said, it's a weekly treatment, and do you have to keep going, or after 12 treatments, you're good for a little bit?
That's a great question. So we do six weekly treatments and then kind of see how it works. And it's 30 minutes a week, every week. And then if it's working okay, we do a total of 12. Mm-hmm. And after that, it's monthly maintenance therapy. And it's going to be 30 minutes a month.
And they come to your office?
Yes.
Okay. Yeah. And somebody does it there?
Yeah. So it can be time consuming.
Mm-hmm.
But depending on where you're at, where you live, and how much you want to avoid these other treatments, it can be worthwhile.
Yeah. Do you send, speaking of physical therapy, do you send a lot of patients to physiotherapy for pelvic floor disorders or?
Yeah.
Yeah.
This, for overactive bladder, it can be very helpful, especially if they don't know how to do Kegels. But I feel like it's something that we don't use as much with overactive bladder, just because it's not necessarily that we need to strengthen the muscles with this. It's we need to help one muscle relax.
Right.
Yeah.
Awesome. Well, we're going to take a quick break. When we get back from the break, we're going to talk about incontinence.
Okay.
The other dirty word.
Yeah.
Thanks. All right. Welcome back. We're going to tackle something pretty big in women's pelvic health, which is incontinence. Mm-hmm. A lot of women suffer from incontinence, and there's all different types. So I'll let you kind of just lead the way with all things incontinence.
Yeah. So incontinence is just the involuntary passage of urine when they're not expecting it or wanting it to happen. So the two main types of leakage of urine, and they often come together, but they're very different problems, is stress incontinence, which is leakage with coughing, laughing, sneezing, jumping, exercising. That's one type. And then the other type is urge incontinence. And so that's a severe manifestation of that urgency that we were talking about, where you feel like you have to rush to the restroom, and if you don't make it, that's urge incontinence. And so they often come together. Like there's a lot of overlap there, and a lot of women have what we call mixed incontinence, which is a combination of those two.
Okay.
Different types.
So I personally have experienced and it's weird. It's when I'm laying down, but like feeling like I have to go to the bathroom, but don't.
Yeah.
And I was like, I think this is positional because it's about laying down and pressure on the bladder. So would that be considered like something like that, or just totally unrelated?
I mean, so different nerves can be firing off, but if there's no leakage, then it's not, then you can get those feelings though, depending on where the nerves are and where the pressure is on the bladder.
Oh. Yeah. Or maybe my mattress is causing different pressure points. So incontinence, what percentage of your patients would you say have incontinence? Or, many different things.
Yeah, of my patients, probably 75%. Yeah, 3/4. So I see it all the time.
All the time.
Yeah.
And how long do they typically wait before they see you?
I mean, usually we're talking decades. They've just lived with it, or it's, most of the time they just have lived with it, not knowing there's any options.
Yeah, I feel like hopefully we're changing the narrative, but I do feel like it's been a dirty word.
Yeah.
Or, as we talked before, somewhat of a badge of honor for motherhood.
Yeah.
And I think it's really time to change the narrative for women and let them know that there are things that can be done.
Right.
So women have waited a long time. By the time they come in, is it so severe that they just can't deal with it anymore? Or did they just learn that it was actually treatable? Or what do you...
I mean, there's quite a variety. Usually it's just so bad that they ended up talking to someone, or they come to the realization that what they're experiencing is more severe than what their friends or sisters or family members have experienced, and so they just want to talk about it. But in reality, I mean, when it comes down to it, if it bothers you, if it stops you from living your life, then talk about it. At least have a conversation so you know the options. You don't have to do anything right now, but you could at least learn the options. And if it ever does become to the point that you want to do something, now you know.
Yeah. So. What causes incontinence? I guess we should start there and kind of...
Well, there's a lot. So we never really know the true cause, but there's a lot of risk factors. And so some of the biggest risk factors are going to be big babies, vaginal deliveries, like forceps deliveries, vacuum deliveries. And so that's a huge component of it. But then there's also smoking, nerve disorder, or disorders that affect the nerves, such as like Parkinson's, diabetes, dementia. Age is a risk factor, postmenopausal, obesity. I mean, there's a lot of different things. Most of what I see, though, is at least somewhat related to birth, like or deliveries, vaginal deliveries.
Okay. I see a lot of commercials. They drive me crazy. I end up screaming at the TV when I see diaper commercials for women that are trying to make them sexy. And they make like lace patterns on them and say, you can't see this, and, this is totally fine. And I get maybe for a segment of people,
right,
that could be the only option, or maybe the choice that would be their choice.
Right.
I just feel like it's frustrating, especially if you're in your 30s or 40s, or if you're a younger person, that might be kind of difficult to have to do every day.
No, I know what you mean. Yeah, it's a useful tool for someone who suffers from incontinence, but the marketing is very disingenuous in that it's not. If you're really trying to help women, you tell them there's other options too. But
diapers aren't the only answer.
Right, and they probably should not be an answer to most women.
Yeah. So what are some of the treatment options for incontinence?
So it all depends on the underlying cause. But for urge incontinence, we've kind of talked about it. It's like very similar treatments, or actually the exact same treatments for overactive bladder.
Oh, really?
For urge incontinence. And that's when you have the urgency to go and you don't make it.
Okay.
And usually these are large amounts of urine that come out, like a complete bladder empty. Very embarrassing and can be very bothersome. The other type of leakage, which is also very common, is stress incontinence. And these are usually small amounts of leakage, usually occurs with activity, coughing, laughing, sneezing, exercising, jumping. And so for that's more of a sphincter issue. So that this is the muscle right near the bladder neck that keeps the urine in. And so that has to do with this muscle. And so the underlying cause is damage to the muscle or to the nerves. And so we try to help support this muscle either by exercising, losing weight. Those Kegels can be especially useful here with that type of leakage. And then there are procedures that can be done to help as well. And there's actually, even before procedures, there's devices. Sorry, I'm jumping around a little bit.
No worries.
There are insertable devices that can be used to help.
Would you use like a Botox for stress or no?
Not for stress incontinence, no.
Okay, only for the urge.
Right.
Because it's...
Yeah, because the urge incontinence, it's more of the bladder wall wanting to contract when it's not supposed to contract.
Right.
For stress incontinence, it's the end muscle, that sphincter, is not contracting when we want it to contract. So it's kind of like the opposite issue. Okay.
We have a lot of women tell us, that they're nervous to have like an implant or surgery or, anything like that, because they're worried. I mean, obviously there's risk with every surgery. But from my understanding, it's pretty safe and it actually really helps.
Yeah. I mean, if we're talking about effectiveness alone, surgery, these types of surgeries are 95% of women are very satisfied with them. 80% are completely dry, like no leakage whatsoever. But just because you're coming into the doctor doesn't mean I'm going to necessarily say you have to have surgery. I'm going to talk to you about all the other options too.
Right.
And so, but surgery for this procedure, it's one of the most, it's very, very successful and very little risk.
And recovery time?
It depends what else needs to be done, because usually if you have this type of leakage, there might be some other issues going on as well. Usually, if you have damage done to the sphincter, there's usually damage done to the other connective tissue, so things might be dropping down. And so those kind of things might need to be addressed too. And that,
so prolapse essentially.
yeah. And that can drastically change recovery time. But if we're just talking about a sling, sorry, but that's the typical surgical procedure, a sling, a mid-urethral sling, then the recovery time is like a weekend as far as being out of work
That's great.
Yeah.
In terms of recovery, right?
Right.
I mean,
I still recommend like no heavy lifting for a couple of weeks, nothing in the vagina for 6 weeks.
and it's outpatient.
It's outpatient.
So no stay in the hospital.
Yep.
Is that a procedure that's done in the office?
It has been done in the office. I do not personally do it in the office. And I think the standard is not to do it in the office.
Yeah, I haven't.
There are other office procedures that can be done, but yeah.
This isn't one of them.
This is not one of them.
I think I've seen a different product, and I don't know if this is what it's used for or if I am pronouncing it right, but it's sacral neuromodulation.
Yeah.
And is that the same thing?
So that is for overactive bladder and the urge incontinence, and that's the sacral nerve stimulation.
Oh, that's the one.
Yeah.
Okay, is that the ankle? Or
no, it's the one. It's an implanted device that goes directly into a wire goes into the spine at the sacral nerve, and you have an implant underneath the fat, kind of in the buttocks area.
Oh,
Yeah.
okay.
So
All right.
a little different, yeah.
All right. So, yeah, I think even me, like I talk about this stuff all the time, and I hear different treatments, and I'm like, oh, what's that?
Yeah.
And I think it is confusing for a lot of women. Like, is it urge? Is it this? Is
Right.
it?
And oftentimes it's both. So yeah, then things really get confusing.
And so a lot of women that are going to listen to this are probably going to be freaked out because they could be in the middle of child rearing, like we're not quite done yet. Does this usually happen many years after, or can it be kind of immediately after childbirth that you would start noticing incontinence or?
Oh, I see what you're saying.
Yeah.
Yeah, usually women tell me that it's soon after childbirth, that's when they started noticing things. And usually things slowly worsen over time.
Okay.
Now, the immediate postpartum period, so after you deliver, that's a unique period where things are healing, things are changing. And so for the first 6 months, everything's kind of up in the air. If you're leaking, 2 weeks after you just delivered,
right.
Give it 6 months and then see what happens.
Especially if you're going to have more children, right? Would you recommend patients do anything in between or maybe exercises to kind of strengthen?
And exercises would be the safest in that scenario. We can consider surgical procedures, but it would be much more, we'd have to discuss the risks and benefits. And one of the risks of having a surgery is that surgery is undone after another birth. Yeah.
Right. I actually had a friend talking to me a few weeks ago, and she has stopped with her 4th child. Mm-hmm. And so she said, I'm ready now.
Yeah.
I'm ready to seek treatment. I'm done. And I definitely need to take care of this, you know? And so I don't know if she was doing the exercises in between, but I'm certainly always talking to my friends about making sure they get treatment. And I think that if I had something that I really wanted to tell the audience today, it would be like, there's nothing to be shameful about with incontinence, and it really isn't a dirty word. And I think, as a society, we've gotten a lot more open, and we're really talking about these things. And there may be diaper commercials saying this is sexy, but the opposite is true, and that they should really have a conversation with you about these things. And it doesn't mean surgery, and it
Right. There's plenty of other options besides surgery.
And early on, like if you see somebody early, is there a way like through physiotherapy that they can maybe stop it from getting worse?
Yeah, especially with stress incontinence. It can be very, very effective doing that pelvic floor physical therapy or physiotherapy and learning how different alternatives to Kegels or different variations of Kegels. But getting that pelvic floor strengthened is very effective.
Yeah, we talk a lot about Kegels in like our patient education booklets and on our website because I think we've heard a lot of women say, I don't know if I'm doing it right.
Yeah.
And I think there's a lot of different things that you can look up. Is there something that you would tell women like how they would know that they're doing it right? Or like,
yeah,
it's hard, right?
It is.
It's different for everybody.
I have a very simple approach. I tell women, at least for the first time, not to do this every time, but for the first time they're trying to engage these muscles, is to stop urination midstream. And that's, again, not a good advice to do that every time. Right. But for the first time, that is the exact muscle that you need to use or you need to strengthen to do a Kegel. And so I tell them to do that and then to start doing that 3 times or 10 repetitions of 3. Or sorry, let me rephrase that. 3 sets of 10 repetitions. And so
how many times a day would you say?
So 3 times a day.
Of
10 repetitions. Yeah.
Okay.
3-second squeeze, 3-second relaxation.
All right, ladies, did you hear that? 3 and 3. So something came to my mind when you were saying that, because we have a big audience, and I'm sure not everybody listening today may have this issue. And I could hear a woman saying, I have the opposite issue. I have a hard time voiding or emptying my bladder. Yeah. Is that in the same realm of this, or is that something just completely different?
That's something that really needs to be looked into, because there's 2 options there, or 2 possibilities there. One is that the bladder's just very sensitive, and so they actually have more like an overactive bladder. And it's kind of like when you have a sunburn on your skin and someone like pats you on the back and it feels like they punched you.
Right.
So that's what the bladder can sometimes feel like. A tiny bit of urine feels like a full bladder. Mm-hmm. That's why you have to go all the time. And you never feel empty because, again, it's just really sensitive. And so in that case, we need to follow more of that overactive bladder type pathway. The other possibility is that they're truly not emptying. And if that's the case, that's not
something
just
completely different, or
that's an issue that needs to be looked into. I mean, it's not just a lifestyle issue. It can damage your kidneys. Not to scare people, but it definitely needs to be looked into.
Yeah, I think I think sometimes I want to scream, like, no, you like, be scared, go to the doctor. It's okay. Like you're fine. Not that it, we want to scare people, but I do want people to really feel an urgency about going, no pun intended, about going to the doctor and making it normal and understanding that there is physical therapy, there's Kegels. I think and I don't know if I'm remembering this right. Is there some sort of like insert that is like a muscle stimulator that it does like Kegels? I think I've seen commercials for that.
There's various devices, and I'm not familiar with every device, but they all deliver electrical impulses to those muscles in the pelvic floor, and they can help you. I mean, there's devices that just sense the pressure difference. And so with your phone, for example, you can see that you're doing a Kegel.
Okay. And
those ones don't really stimulate, but you can also get the ones that actually deliver electrical impulses and kind of force it to Kegel. If they're designed well, it shouldn't be painful, but
yeah, I don't know. I just think I've seen commercials, maybe online, maybe on Instagram or something like that. So I didn't know how widely used those are, but it sounds like it's pretty simple to do them on your own. You don't have to buy a device
right
to do it. You can do it any time of day.
Right.
Just sitting and nobody will ever know. It's nothing to be embarrassed about.
I would say the first thing, do it on your own. Second thing, pelvic floor physical therapy, where you have someone specialized in this to kind of walk you through it. And then if you still are struggling, then there's these devices. And there's the stimulators, which you referenced. There's actually weights that you can buy online. So you buy these different kind of variations in cones or balls, and you kind of go up in the weight and try to keep it there for a certain amount of time. But it's all doing the same thing.
Are those yoni eggs? Is that what that...
Again, there's different.
Okay.
Yeah, there's multiple different products, but probably I'm not familiar with the brands. But
I had one more question, and it slipped my mind. So we'll have to pick it up next time.
All right.
Thank you so much for stopping by. We really appreciate it, and it was great talking to you today.
It was nice talking to you too.
All right.